So lastly, for the last talk of today, it's going to be a talk by Daniel Ridani, who is a master student at Université Polytechnique de Montreal in the Department of Biomedical Engineering. So his talk is also going to be a pre-recorded talk, but I think he's here right now, so maybe we can ask questions directly to him at the end of the talk.
Hello everyone, my name is Daniel Ridani, and today I'll be talking about the development and comparison of an image reconstruction pipeline to assess brain oxygenation in neonatal asphyxia using quantitative susceptibility mapping QSM. I would like first to start with a quick definition of quantitative susceptibility mapping. First of all, quantitative means numerical values. Susceptibility means how much a material will become magnetized in an applied magnetic field. And mappings mean create a map of this susceptibility. I would like to start first with a quick background about neonatal hypoxic ischemic encephalopathy HIE, which is a perinatal complication resulting in reduced cerebral blood flow and oxygen delivery. It can affect between 1.5 to 2.5 cases per 1,000 live births in developed countries. Adverse neurodevelopmental outcomes or even death can affect 40 to 60% of infants. Therapeutic hypothermia is the only clinical treatment for HIE, and it consists in cooling the patients during the first 72 hours of age. Although hypothermia improved the survival rate and reduced severe neurodevelopmental disability, a significant number of neonatals still suffer from brain injury and adverse neurodevelopmental outcomes. So early markers of impaired cerebral venous oxygen saturation or CSVO2 may help to detect brain injury on post-therapy MRI and help to improve long-term outcomes. To measure the oxygenation levels, we have two methods, even invasive or non-invasive, but current non-invasive methods that measure the oxygenation like near-infrared resonance spectroscopy has been shown to have poor sensitivity at low CSVO2 levels. And one of the leading techniques to quantify the human brain is QSM, which is an emerging MRI method that allows to quantify CSVO2 levels. So in this presentation, we aim to reconstruct QSM images using different reconstruction algorithms, compare susceptibility values generated, compare the quality using different matrices, and to quantify the level of CSVO2 in patients who underwent hypothermia for HIE. We think that the quantification for CSVO2 depends on the technique used to reconstruct images, and the susceptibility values may vary within the brain. In order to do this, we acquired T1 weighted and multi-echo graded echo data using a 3 Tesla MRI scanner from 16 patients aged between 4 and 14 days who were diagnosed with HIE and underwent hypothermia, and we use these parameters as shown here in the table. This is the full QSM pipeline that we use to reconstruct QSM images. So after data acquisition and using the magnitude image to extract a mask, the phase image was unwrapped using a phase unwrapping algorithm, which in our case was Laplacian phase unwrap. And after that, a background field removal and the dipole methods are applied. And finally, to analyze these images, we apply the segmentation and registration methods to divide the brain into different regions that we can use later. In this presentation, I'll be more interested in changing the background field removal and the dipole inversion methods to create a new algorithm of QSM reconstruction. These are all the methods that we use for the background field removal and dipole inversion. We divided the experiments into two groups. The first group, which consists of fixing the background field removal methods, in our case the resharp methods, and combining it with each of the dipole inversion methods. And for the second group, we fixed the dipole inversion methods on RTS and we combined it with each of the background field removal methods. So we have in total 13 methods to reconstruct QSM images. In order to compare these methods, I'll be presenting two quality matrices. The first one is the white matter homogeneity, which can be considered as the proxy measure for residual background and frequency artifact. The second one is the veins contrast, that can be obtained by drawing a perpendicular line to the veins in order to get the profile graph, and by dividing the maximum intensity with the full wave half maximum, we can get the veins contrast. And the third one is not actually a quality matrix, but I'll be extracting the oxygenation levels in the cerebral veins, also known as CSVO2, using the following equation. And finally, the susceptibility values will also be calculated as well for different regions. I would like to start first with a visual comparison between all the reconstructed images. Although all the methods show robust QSM reconstructions, some methods perform better than others. As we can see here, that some methods have hypersignals like the third one, and some methods like the first two have signal dropouts. In addition, we can also notice that for the same pattern of signal dropouts indicated here in the red arrow, some methods emphasize the signal dropout, but others decrease the effect of it. The susceptibility values were compared using a violin plot that represent the susceptibility values for two regions, the CSF and the caudate nucleus, using all the reconstruction methods in two example patients represented in the rows. The spatial location of the region of interest is represented by the brain in the middle of the reconstruction methods. We can see that for the dipole inversion methods, the TIKH had the highest variability, and for the background field removal, LBV has the higher variability, which indicates that these methods were not consistent in calculating the susceptibility values, and which also can be explained by the random signal dropouts in the corresponding regions. Now, let's compare the quality of the reconstructed images. If we assume that the white matter of QSM images should mostly be homogeneous if the processing pipeline is reliable, we calculated the standard deviation of mean susceptibility in the white matter area using a template to identify this region to determine white matter homogeneity. Low homogeneity or high standard deviation are probable sign of low spatial frequency artifact and residual background phase components. We can see that for the dipole inversion methods, the SSTGV and TSVD showed the highest values of homogeneity of white matter, while MEDI and TIKH showed the worst. And for the background field removal methods, PDF was the best methods, while LBV scored the lowest values. Now, let's move to the second quality matrix, which is the veins contrast. As I previously said, we can calculate this matrix by dividing the maximum intensity by the width of the vein. We can notice that for the dipole inversion methods, the TIKH once again scored the lowest values, and for the background field removal method, there was no significant difference. Now, let's compare these veins by visual comparison. By looking at the zoomed-in image of the veins, we can notice that these images were in line with the values. One reason that can affect these images is the image smoothness. The higher the image is smooth, the harder it is to identify boundaries, which will make the veins larger, which thus will make the contrast lower. And finally, the CSVO2 levels were extracted and compared using all the reconstruction methods. The majority of the values were a normal range of oxygenation, which is between 60 and 80%. And our results were comparable with other articles that calculated the oxygenation levels using QSM. To sum up everything, quantitative susceptibility mapping of the neonatal brain is challenging due to the motion of the newborn, the smaller brain structure, and the shorter acquisition time. This study compared specific image reconstruction algorithm. The result demonstrates robust QSM values in neonatal brain, as shown by a parent of small structures such as blood vessels. The susceptibility values and the oxygenation values were in agreement with the literature. Future work will include new matrices to establish a golden standard and to select the best methods in terms of reliability, reproducibility, speed, and efficiency, as well as maybe combining other modalities with QSM in order to further understand neonatal HIE. Now, for the limitation, QSM actually don't have a golden standard, although a method called Cosmos is often considered as the golden standard, but it's actually really hard to acquire Cosmos data, especially for newborn. We were biased against other methods since we only used the most popular methods and the more easily accessible methods, ignoring other new methods that can be as good. And finally, in this project, we don't actually have healthy controls to compare the results that we got. This study was supported by Polytechnique Montreal, by the Canada First Research Excellence Fund, and by the Transmatech Institute. And I would also like to thank the newborns family who agreed to be part of this research. This study would not be possible without them. Thank you everyone for listening for my presentation. If you have questions, please don't hesitate to ask them. Thank you.
Okay, so thank you for your talk, Daniel.